Okay. So I think we these days with these virtual kind of meetings, all the meetings start off with, can you hear me? Can you see my slides? So are they both okay? Can you hear me and you can see my slides, right?
Yes, yes.
Okay, great. Thank you so much. And really, I was chatting with Dr. Saptarshi and Dr. Mittal and Dr. Lakshmi and Dr. Ganapati before we started. And really, I consider it as a incredible privilege to be invited to speak, because India is always home to me. And I treasure my childhood spent in India, and to me, this is no privilege can be greater than this, to come back and speak at least virtually in India. So I've been given a rather unusual topic, that the whole session today, the whole symposium itself today is very unusual, and I'm very impressed because I didn't even know that there was such a thing called World Autoimmune day. So it's really an honor to speak today. So it's an unusual topic, and I'll try to do justice to it in the short 20-25 minutes that I have. So we have come a long way in the management of osteoporosis, pharmacological management of osteoporosis. We have a plethora of drugs available right from the time in the early 1970s, 1980s, when hormone replacement therapy was advocated for the prevention and treatment of postmenopausal osteoporosis. We moved on from there to the selective estrogen receptor modulators. Calcitonin had a brief, nasal calcitonin had a brief surge in popularity in the 1990s. And then, of course, we have the mainstay of our treatment, which is essentially bisphosphonates, which can be the oral bisphosphonates and the IV bisphosphonates, zoledronic acid, which was approved in the early 2000s. So we do have a plethora of drugs available, but are we still searching? Have we reached the holy grail yet? Have we gotten that holy grail of osteoporosis treatment, which we have been boneheads like me and Lakshmi, for instance, have been searching for all our lives? Have we attained that perfect drug which will cure osteoporosis? Probably not, but still we are on our way there, and we have our horizons have expanded in recent years. And I'm not saying that we have come up with this magic bullet or integrated circuit pill for the management of osteoporosis yet, but lots of exciting developments have happened in the last several years. And I'll focus on obviously the topic which I've been given to speak about today, which is biologicals in the management of osteoporosis. So we have actually moved away from what I call a serendipitous pharmacology. And serendipitous meaning literally we stumbled upon the fact that some of these medications like bisphosphonates could be used to treat postmenopausal osteoporosis. Bisphosphonates, for the youngsters in the crowd who don't know this, bisphosphonates were actually used as pipe cleaners originally. So it was really not earth-shaking science which led to the discovery of these medications. It was literally a very serendipitous discovery. We literally stumbled upon them. So moving away from that serendipitous pharmacology, we have moved away right now to more targeted therapy. We have come up with a lot of interesting molecules, which hopefully will help us to kind of kill off osteoporosis as a disease from humankind. So the Art of War by Sun Tzu essentially says that if you know your enemy, and if you know him well, you need not fear being defeated in the battle. So essentially what we need to do, understand, is the pathophysiology of osteoporosis and develop molecules that can specifically target key points in the osteoporosis pathophysiological cascade, and thereby treat this devastating disease. And I'm just putting it up there for you right now. So you have agents which can probably target osteoclastic bone resorption, such as Denosumab and Odanacatab, which fell by the wayside. And on the other hand, you have the anabolics, again, targeting specific molecules in the osteoblastic bone formation pathway. So we'll talk about all that in a bit. So the what is biologicals really, when I got this topic, I'm kind of embarrassed to say that I actually had to go and look up, just to make sure that I'm going to be talking about the right thing. So the central theme of recombinant technology or genetic engineering is a process of gene cloning. So by which what you do is that you're producing a defined fragment of DNA, and then you propagate and amplify it in a suitable host cell. And that's why it's called biological, because it's produced in a biological cell. And the drugs developed by recombinant technology or genetic engineering are known as biologicals, biopharmaceuticals, recombinant DNA express products, bioengineered or genetically engineered drugs. So in the field of osteoporosis, we have three biologicals which have already been developed, and I'll be focusing my talk today on these three. Number one is human recombinant PTH or teriparatide. You have the rank ligand inhibitor denosumab, and then the newest kid on the block, which is sclerostin antibody inhibitor or romosozumab. So the unfolding of the teriparatide story. So for oldies like me, I mean, even for oldies like me, this is beyond or earlier than my time, when I started delving into bone metabolism. But the unfolding of the teriparatide story is actually very interesting for those of you who are interested to know. So teriparatide or recombinant human teriparatide is actually the N-terminal fragment, 34 amino acid fragment of the native parathyroid hormone, which has got 84 amino acids. And the reason why it's a biological is that because this recombinant human teriparatide is produced in E. coli. And so actually the introduction of Forteo or Forsteo or whatever it was, branded as in 2003 actually marked the beginning of the biological era in the treatment of osteoporosis. So this was like a major landmark in the field of biological treatment of osteoporosis. And I'll just leave this up here for a second because obviously I don't have time to go through this. But again, people who are interested to know about the history of how parathyroid or human recombinant PTH was developed, it's a very, very interesting story. So way back in the 1920s, we knew that PTH existed. We knew that parathyroid, it was called parathormone at that time. But then and in the early 1930s, actually PTH's role in bone metabolism was shown, but then it kind of languished till like the late 1970s. And then it was only in 1980 that actually the first human trial in patients with osteoporosis was done. But despite that, again, things kind of languished quite a bit till 2001. So another 20 years went by, more than that. Yeah, about 20, 21 years went by before the pivotal phase 3 study of teriparatide by Neer and his group found out that teriparatide can be used for fracture prevention post-menopausal women with osteoporosis. But then came a big stumbling block there. The fracture prevention trial by Neer, it was going along very smoothly. And then it was found that Fisher rats, Fisher 344 rats, who have a genetic propensity because they don't fuse their epiphysis, they developed osteosarcoma when given supraphysiological doses of teriparatide. So actually the study had to be stopped before it could really be completed. It had to be stopped at 2 years. So it is because of that development of osteosarcoma in Fisher rats who are predisposed to develop osteosarcoma, that teriparatide is recommended the world over to be given only for 2 years. And osteosarcoma, of course, I mean, in the number of trials, the observational trials, as well as the randomized clinical trials, as well as real life exposure studies, osteosarcoma has not been reported in humans at the 20 microgram daily dose that it's prescribed currently. But still, that was teriparatide's fate. So the endocrinology, the DM fellows in the crowd and the young registrars in the crowd would obviously be asking, how can teriparatide cause an anabolic effect when we all know primary hyperparathyroidism is associated with increased bone resorption. So the key thing is that here, when teriparatide is given intermittently as a once a day dose, as opposed to a continuous onslaught of PTH, which the human body has to suffer in situations of primary hyperparathyroidism, it actually has an anabolic effect. And again, you can read through the slide. Essentially, what happens is that when it's administered intermittently, there is activation of specific genes that respond specifically to this transiently activated signaling system. So under these conditions, PTH is anabolic. And this is an interesting concept again. There is a bitemporal distribution of bone turnover markers when teriparatide is given. And this is called the anabolic window. And this is what you're trying to kind of capitalize on and maximize on. So when you give teriparatide, initially you get a rapid rise in bone formation markers, but also you have a slower increase in bone resorption markers. So before the bone resorption markers start increasing, this is the anabolic window which you want to capitalize on. And this is a period of time when teriparatide treatment is maximally anabolic. So the pivotal trial, I'll just go through these quickly. The pivotal trial of teriparatide was a fracture prevention trial, which was basically 20 microgram daily or 40 microgram of recombinant human PTH. And this was Neer was the first author, and essentially the 20 microgram daily showed a relative risk reduction of 65% in new vertebral fractures. There was also a 53% reduction in non-vertebral fractures. But like I said, because unfortunately the trial had to be stopped before completion, we did not have statistical power to look at hip fractures. So as of now, teriparatide has not been shown to decrease hip fractures, but it's intuitively, it does make sense that it probably will, but still it had to be stopped before we could complete the trial. So that's teriparatide, dramatic reduction in vertebral as well as non-vertebral fracture risk reduction. No data on hip fractures per se. And this is the VERO trial in which when teriparatide was compared with risedronate, again, compared to risedronate, teriparatide significantly reduced new vertebral fractures at 12 months as well as at 24 months. So superior, shown to be superior to risedronate, regardless of whether the person has a prior osteoporosis treatment. And this was noticed even in severe existing osteoporosis. So teriparatide was much better. In anabolic therapy such as teriparatide was found to be much better than an anti-resorptive therapy like risedronate. So that's a VERO trial. And just two slides. Again, I know there are orthopedicians in the crowd, so I'm sure this is something which is of great interest to the orthopedic surgeons, but whether fracture healing is helped with teriparatide. Again, the data is very conflicting. There are lots and lots of case reports and case studies. However, in human subjects, the only data that I could find was the 20 micrograms of teriparatide, but not the 40 microgram, reduced median time to radiographic healing in radius fractures. Though there are plenty of case reports and case studies around. And if we have time, we can talk about why this is so, why the 20 microgram, but not the 40 microgram. And then again, the other question is whether it aids with osteonecrosis of the jaw, whether it can be used to treat osteonecrosis of the jaw, whether it can be used to treat atypical fractures. Again, the orthopedic surgeons, I know they use it, but again, the data is very conflicting. Most of it is just case studies. Really, at this point in time, the data does not suggest, there's no strong evidence to suggests that teriparatide can be used for either fracture healing or for atypical fractures or for osteonecrosis of the jaw. But of course, there are anecdotal case reports. Now, teriparatide is costly. I'm not sure how much it is in India. I was told by Ambrish this morning that you do have a biosimilar for teriparatide in India, so great. But in Singapore, at the present time, it's not off patent, so it's about $750, Singapore $750 per month, as opposed to say something like Denosumab, which is about $87 per month. So people have started thinking about whether cyclical teriparatide can be given, and this was actually Felicia Kosman has looked at this data in which she treated either treatment naive or alendronate pre-treated, and then this alendronate was continued while the patient got daily teriparatide for 3 months on, followed by 3 months off. And what was shown was that in the previously alendronate treated people, BMD increases were pretty much the same in the 3-month on, 3-month off group as compared to the daily teriparatide group. So possibly this may be considered. We do not have fracture data yet. And so similar BMD gains in cyclical versus daily teriparatide in women on alendronate therapy. So that was teriparatide, right? So the first biological that was developed in the treatment of osteoporosis, done and dusted. We have kind of, I've shown you the data on teriparatide. Fantastic agent, decreases both vertebral as well as non-vertebral fractures. Hip fractures, the data we really don't have. And there is suggestions that teriparatide may increase cortical porosity, etc. So there are these concerns anyway. So now we come to the only two monoclonal antibody biologicals which we have in the treatment of osteoporosis. Again, I had to go Googling, okay, what exactly is a monoclonal antibody? So a monoclonal antibody is an antibody made by cloning a unique white blood cell. So all the subsequent antibodies derived this way can trace back to a unique parent cell. Now, the beauty of monoclonal antibodies is that they have a very high degree of specificity for a particular antigen or epitope. But the problem is that the early monoclonal antibodies which were developed were actually created by fusing spleen cells from an immunized mouse with human or mouse myeloma cells. And so this resulted in a lot of immune reactions, etc., etc. So then subsequently, through a range of these kind of methods, which obviously I'm not going to be talking about today, through a range of these methods, you were able to develop, humankind was able to develop either fully human or humanized monoclonal antibodies. And this was actually news to me. So if it's fully human, these monoclonal antibodies end with a UMAB, okay? And whereas if it is humanized, not fully human, it ends with a ZUMAB. So this was kind of a little trivia which I found interesting. So Romosozumab is humanized, whereas a fully human would be a Denosumab. Monoclonal antibody. And so just quickly about Denosumab, rank ligand is essential for osteoclast formation, function, survival. And obviously we all know this, osteoblasts produce rank ligand. Rank ligand then goes and binds to the rank receptor on the osteoclast and causes it to replicate and facilitates osteoclastogenesis. OPG, or osteoprotogerrin, which is also produced by osteoblasts, acts as a decoy receptor and prevents rank ligand from binding to the rank receptor in the osteoclast. So again, I'll just skip through this. So the earlier attempts were tried at making OPG and FC-OPG, etc., but they were not really successful. So denosumab is a human monoclonal antibody to rank ligand. It binds human rank ligand with high affinity and specificity and inhibits rank ligand action. So there have been several studies with denosumab. Of course, the pivotal trial is a FREEDOM study, which looked at postmenopausal women and was a phase 3 randomized controlled trial in postmenopausal women with quite bad osteoporosis with baseline T-scores less than -2. So they were randomized to denosumab or placebo every 6 months for 36 months. And again, excellent fracture reduction, both vertebral, non-vertebral, as well as hip fracture reduction was seen. And now we have the FREEDOM extension trial, which has continued for up to 10 years. And again, this seems to suggest good BMD improvements all the way up to 10 years, which and also by this particular study using a virtual twin placebo, it seems that the increase in BMD is sustained up to 10 years, and that results in a decrease in fractures. And so this is where the concept of can a specific T-score be a target of treatment, because denosumab was found to actually, increase BMD all the way up to -1.5 to -2, and this resulted in a decreased risk of fracture. So maybe a target of -1.5 to -2 could be a possible target in osteoporosis treatment. Just one quick word about the vertebral fractures after discontinuation of denosumab. Very, very important. There is an increased rebound risk of vertebral fractures after discontinuation of denosumab, and this is especially during COVID. I'm not sure how, again, in India. In Singapore, we are facing this problem where people are not coming to the hospitals, to the medical centers to get the denosumab injection. So we are in a little pickle right now because, again, we are very concerned about the rebound risk in vertebral fractures which can happen. So the last part of my talk is basically now the third and the final monoclonal antibody, the second monoclonal antibody actually, which we have. And this is where the study of rare skeletal disorders has helped us tremendously, moving from the serendipitous pharmacology, stumbling upon a pipe cleaner as a treatment for osteoporosis, a targeted treatment. And this all began with the discovery of this disease called sclerostosis in South Africa. And it was actually reported by a registrar in 1958. And then subsequently, more stories came up from the US. There was this person who had this car crash, which would have left anybody else completely shattered like glass. But he walked out of this car crash completely unscathed. And he just happened to mention, you know, I never swim because I keep sinking. So he had very dense bones on x-rays. And this, as well as study of a couple of other families, led to the discovery of LRP5 gene. So this is actually where sclerostosis and Van Buchem disease, which are two of these sclerosing bone disorders, come. Sclerostosis is an autosomal recessive sclerosing bone dysplasia. There's fracture resistance here. And Van Buchem disease, a disorder downstream and less milder than sclerostosis, but still associated very, very, very thick bones, as you can see. So this study of sclerostosis actually led to an insight into the pathophysiology of what is now known as sclerostosis. And for that, you just have to understand these very weird little molecules like Wnt and frizzled and disheveled and groucho, etc. And this is where the Wnt signaling pathway comes into play. And I'm not going to bore you with details about this, but essentially the Wnt signaling pathway is important in osteoblastic bone formation. Essentially what happens is that the Wnt molecule binds to LRP5, LRP6, and this then results in stabilization of beta catenin, and anyway, ultimately it results in bone formation, increased bone formation. Now, antagonists to Wnt signaling, such as sclerostin, bind to prevent Wnt from binding to LRP5, LRP6, and this then obviously that cascade is interrupted and you get beta catenin degradation and you get decreased bone formation. So obviously the logic is that if you can come up with an inhibitor to sclerostin, then that can result in increased bone formation. So at this point you must be like, what the heck is this woman talking about? But obviously it is so important that if you're one of those people who are interested in these rare exotic meetings, please feel free to go attend this after COVID. Apparently they have a European Wnt meeting every couple of years. So if you're interested, you might just want to go there. So obviously if you can target the Wnt signaling pathway, you can maybe help in increase bone formation. There are several molecules which can be targeted, but inhibition of sclerostin is the most promising. And this is where Romosozumab, which is the newest kid on the block, has been shown to increase bone formation because it's a sclerostin antibody. It inhibits sclerostin, and there have been several studies again with Romosozumab, of which the most important, the pivotal trial, was a FRAME study, which I'll just briefly go through, in which postmenopausal women with osteoporosis were assigned to either Romosozumab or placebo, followed by 1 year of open label denosumab. And what was shown was that there was a remarkable decrease in vertebral fractures. The non-vertebral fracture risk reduction, there is a little bit of confusion there because though it didn't reach statistical significance, but that we think is because these Latin Americans who formed a big part of this study cohort, they have baseline low risk risk of non-vertebral fracture. So it's presumed it's because of that. But anyway, fantastic reduction in vertebral fractures. Most importantly, this frame study laid what's called the foundation effect, which means that if you can build bone in the first 1 year with an anabolic agent, then transition to an anti-resorptive agent, you get continued benefit. So this is what's called the foundation effect, in which we start off with an anabolic agent and then subsequently transition to an anti-resorptive. Now, there is the ARCH study, which I do have to mention. So great. There are lots of other studies which showed fantastic results with Romosozumab. In the ARCH study, Romosozumab was compared to alendronate and the first 1 year. And then in the second year, both groups were transitioned to alendronate. And again, you got great vertebral fracture risk reduction. You also saw a non-vertebral fracture risk reduction at 12 months and 24 months. But the one thing which popped up was that in the ARCH study was that there was a concerning safety signal with new serious cardiovascular events in the Romosozumab group at 1 year. Now, we really don't know what the reason for this is. And this was definitely seen as adjudicated cardiovascular events were seen in the Romosozumab group in the first 1 year, but there does not seem to be a pathophysiologic mechanism which can explain this. And it was not seen in the earlier frame study where Romosozumab was transitioned to Denosumab. So in the frame study, there was no difference in adjudicated cardiovascular events between the Romosozumab group and the placebo group. And we really don't know why exactly this has happened. The genetic, clinical, and non-clinical kind of postulates cannot explain this. So the bottom line is that at this point, it seems that this is most likely secondary to chance. But just as a caveat, so we have these monoclonal antibodies and the Wnt signaling pathway which has been targeted, but you do have to remember that Wnt proteins are ubiquitous in the body, and we don't know what really tampering with these Wnt molecules can result in. So we are still kind of keeping an eye out for all this. So the last couple of slides, basically, so I've talked about what's currently available. Now we are moving on to what is in the future. PTH preparations in clinical trials include nasal and pulmonary inhalation of PTH 1-34. A transdermal patch is being tried out. Oral teriparatide is being looked at, and something called Osteborlin C, which is a small PTH analog. So these are all being looked at. And again, there are other agents which are being considered in the development of small molecule development in osteoporosis treatment. Anti-DICOF1 antibody, which is again an inhibitor of the Wnt signaling pathway. Calcilytics, the opposite of calcimimetics, they've not shown to have evidence so far. And I'm just leaving it there for you because these are all exciting new things. And there are these little things called aptamers, which are not really biologicals, but are single-stranded oligonucleotides, which can target rank ligand, which can target sclerostin, etc. So these are all exciting things which are going to be coming up soon. So with that, I know it was in 20 minutes, this is all I could do, but just a rapid rush through. And this was actually taken when Ambrish was with us in 2019, when he was speaking at our skeletal rare disorder symposium. So one of my registrars at that time took this fantastic picture of him and put up this caption, and Prof. Ambrish looking at the bright future of biologicals. So with that, and thank you very